noise or anything, can you guys just please confirm me in the chat? Is my voice loud and clear? Is there any disturbance or anything? Can someone confirm? Hello? Okay, that's fine. Thank you, Dr. Pamela. Thank you. Thank you. Thank you, everyone. Thank you, Dr. Jyoti. Thank you. Hello. Yes. We will wait for just another 2 minutes. I'm going to start. Okay. If anyone wants to join, let them come. Another 2 more minutes. I'm going to join. I'm going to start. Okay. Yeah. All right, let's begin. It's about time. Okay. Now we are going to start with our clinical form. And some of you are maybe new to our lecture, I think, and who have enrolled just for this clinical pharmacology. All of you are most welcome from the MedExpert team. Okay. We are going to start with clinical form today. I will just give a brief introduction about what we are going to do for the next 4 days. Okay, it's going to be 4-day lecture. Okay, first 2 days, I'm telling you what we are going to do. Okay, first, we are going to see about gender pharmacology, and second, gender form. On the second day, even the later half of today, we are going to start with some systemic pharmacology. And second day, again, we are going to do some systemic pharmacology. And on the third day, we will start with toxicology, plus some MCQs. On the fourth day, we're going to do some MCQs. The reason why I wanted to do MCQs is because I actually wanted to work out some MCQs with you, which I consider that could be asked for your exams. That's more in line with Royal College exams. So I just picked up a couple of MCQs from different banks and some past papers and stuff. So we will be discussing all that. I wanted to work out MCQs with you because I saw the way some of the candidates are working. I'm not criticizing anyone. They need help. So I'm ready to do the help. That's the reason I just stretched it for 4 days. And I believe all of you knows that clinical pharmacology is a very important subject. I would say it's the most important subject. Okay, most important subject for your MRCP part 1. And people who have already appeared for the MRCP part 1, maybe unfortunately who haven't gone through them, they know very well why clinical pharm is very important. Okay, and that's the reason we are having the most extended lecture. I would boldly say nobody, no firm, no coaching center, and no training center is having this much extensive lecture on clinical pharmacology, especially tailored to MRCP Part 1, which we are going to do now. Okay. And one more thing I'm requesting you, first 2 days, the lecture will take time because I have to cover everything. I want to be true to my consent and I want to be true before God. So I want to cover most of the things. Okay. So it's going to take some time. So please be patient. If you guys are like too tired or something, please let me know. We can take a break. We can go ahead and we can have a cup of coffee or tea, whatever you like to have. And then we can again come back and start. Okay, first 2 days, it's going to be, yeah, you're most welcome, Dr. Haider. Okay, first 2 days, it's going to be a little bit more time. I will do my very best. Okay. And second thing, unlike other lectures, clinical pharmacology has some concepts in the beginning. The rest of the things are like, you know it or not. You have to memorize stuff. I'll be little speeding up, okay? Because if I'm gonna take it too slow, the entire week we'll be only only learning clinical pharmacology only. I don't want that to happen. So I'll be little fast. So I want you all to pay careful attention and catch up with things. Otherwise, you will end up losing the track. All right. With this introduction, I'm going to start with clinical pharmacology for MRCP from MedExpert, okay? And new people who haven't been to my lecture, you're most welcome. And our candidates and our trainees are already here and really happy to see them as well, okay? And yeah, like I said, our milestones are going to be general form, systemic form, toxicology, plus MCQ discussion. Okay, we are going to discuss somewhere close to 120 plus MCQs. Okay, this is the longest ever MCQ discussion I have done, but I wanted to do it this time with for everyone. Okay, we are going to discuss 120 plus MCQs. Okay, all right, with that we will go. With general pharmacology, I want all of you to carefully understand some concepts. Okay, if you don't know this concept, learning pharmacology is going to be completely fruitless and useless. All right, so some concepts are very, very important. And mind you, it can be a little boring. It's not like a clinical science where I can just get a patient and show you all the exciting findings and quickly go on to guidelines and work out MCQs and leave. This is not going to be like that. This can be a little dry. This can be a little boring. Until we are going to reach the toxicology part, it might be slightly boring. Just bear with that. We are going to start with the very first concept, that is the pharmacokinetics and pharmacodynamics. So, okay, first, what is a pharmacokinetics? Simple word, they tell what body does to the drug. When you're putting a drug inside, what your body does to that. Okay, just imagine some intruder is coming into your home. How are you going to react? Or imagine a guest is coming to your home. How are you going to react to the guest? That's what all about pharmacokinetics. What your body do to the drug which is incoming. It can come through your mouth or come through your vein or come through any other form. It can a drug. It can be applied topically. Anyways, once a drug comes, what happens? 4 things. That's what they call as ADME. All right, they call it as an ADME. First thing, absorption. Okay, the drug will be absorbed into your body, okay, through any surface, like it can be oral, sublingual, IV, anywhere. First, it's absorbed. Second is distributed. Okay, the drug that comes into your body is distributed equally to all your systems. That's the second thing. Number 3 is the metabolism of the drug. The drug gets metabolized, and finally, the drug gets excreted. Pharmacokinetics, we in short form call PK. This covers all these things, how the drug is absorbed into your body. Okay, and just take, for example, this is a human. Okay, this is a human being. Okay, he is orally taking a pill. Okay, maybe he's swallowing up aspirin. The entire pharmacokinetics about how the aspirin goes in, that is absorbed, and how it is distributed, and how it is metabolized, and how it is excreted out. This is pharmacokinetics. The next concept is going to be pharmacodynamics. What is a pharmacodynamics? This is what the drug does to the body. For example, a guest is coming into your house. What the guest is offering you, what the guest is going to get for you. Maybe he would have got some sweets. Maybe he would have got some toys for your children. That's all about pharmacodynamics. What this drug is going to do to your body. All right. What this drug is going to do to your body. All right. That's pharmacodynamics. At least know this simple concept. Make it simple. Just remember the analogy of a guest and remember ADME. That's more than enough. That's more than enough. The next concept is going to be volume of distribution. This is important because sometimes they do ask Sometimes, very rarely, they do ask some calculations based on this. Okay, I'm not a great mathematician. Max is so far away from me, but still, I'll at least give you the formula. You may be able to work it out. Okay, the volume of distribution, better term is going to be always the apparent volume of distribution. We call it as a VD. What is a volume of distribution? You should be knowing. Okay, and it's another important PK parameter. Like I said, PK I'm going to use for pharmacokinetic parameter. Okay, it's nothing other than the estimation of how much drug is distributed in your extracellular fluid. How much drug is going to be distributed in your body. Okay, maybe you are taking, for example, 150 milligram of ecospirin. Not the entire 150 milligram is going to go and distributed in your body. For example, we will go back to the analogy of a guest. If a guest is coming, you're not going to go and give the entire food or sweets or whatever you're having in your home. You're going to give what is adequate for that particular person. Okay, like that. What amount of drug is distributed in the extracellular fluid? That's what you call as your volume of distribution. It's very important because there is a formula for it. You need to know this formula, okay? Because on an odd day, they may ask you, then you shouldn't end up, what the hell is this in this paper? I don't even understand. I don't want any one of you to stand like that. So this is a formula. There is no other way, you have to memorize. So what is the volume of distribution? Volume of distribution is equal to F into D, dose by TC. What is D, dose, what is TC, what is F? Everything is important. F is the bioavailability of the drug. I will tell you what is a bioavailability. Okay, I will tell you what is a bioavailability, and I will explain the concept to you as well. So no need to worry about that. Okay, D is the dosage. What is the dosage of the drug? T is the target plasma concentration. What target plasma concentration you want the drug to be? All right. So remember this formula. Volume of distribution equal to F into dosage divided by target plasma concentration. I'm also telling you, they may give any value here in this formula, and they may ask you to derive anything out of it. I hope you understand. They may give you any value in this formula, and they may ask you to derive anything out of this. Be ready. Okay, it's the same. For example, they may ask you to calculate the dose. Then you have to derive it. All right, then you have to derive it. This is the formula for volume of distribution. This is how you have to calculate. These are the parameters involved in it. I hope all of you understand. We will go to the next parameter. I want all of you to notice the maintenance dose. This has been asked in your previous paper, not the last year paper. I think I have seen around 2 to 3 years back paper they had asked, how do you calculate maintenance dose? Also, clinically, you should be knowing this. In UK, we have BNF. Okay, how many of you are aware of BNF? I don't know. BNF is British National Formulary. And I always keep up to date, though up to date is not UK based, but I still believe up to date has a good potential. We immediately calculate the drugs. There is nothing wrong in not knowing the maintenance dose for every single drug. We may not be able to. Here, UK NHS accepts that. It allows the people to go ahead and check with BNF, check the drug compatibility, everything, and come back. So maintenance dose, you should know. Maintenance dose formula is equal to clearance into target concentration. You divide that with the bioavailability into dosing interval. Okay, this is how you are going to calculate maintenance dose. All right, clearance into target plasma concentration divided by bioavailability into dosing interval. This formula you have to memorize. There is no other go. This formula you have to memorize. Okay, for people who are having a bitter experience with mathematics, these are some of the things you cannot get away in an MRCP part 1. Next is going to be biostatistics. That's a totally different horror story. Okay, these are the 2 formulas I want you to know. I hope all of you know what is VD, pharmacokinetics, pharmacodynamics. Okay, with this, now comes to the first pass metabolism. What is the first pass metabolism? This is the process, this is a type of metabolism where the concentration of drug is reduced before it can enter the systemic circulation. Okay, like I said, again, we will go back to the example of an aspirin. Okay, aspirin or ecospirin. Okay, you are giving a 350 milligram to somebody. Okay, or you're crushing some 375 milligram in ice and giving to someone having his MI or anything. Not the entire 350 milligram is going to reach your body. Okay, it has to undergo this first pass metabolism. Okay, where this is reduced. 350 milligram can become 150. Depends on so many other things, like how his metabolism is, how his renal function, how his liver function, gut function, everything. Based on that, it will be reduced. That reduction in the actual dose is known as your first pass metabolism. Okay, like I said, it's always defined by your intestines, your hepatic health, okay, and your renal health. Everything determines how much drug is going to be reduced, okay, before it can enter the systemic circulation. All right. Also, the enzymes on the GI lumen, gut wall, everything determines that, including your gut bacteria. Now, gut bacteria is actually good. That's a symbiotic relationship we have with the gut bacteria. Almighty has created the bacteria to actually protect us. But what is happening nowadays? They are giving as much antibiotics as possible and completely killing the good bacteria, so that so many other unwanted sickness we are getting these days. All right. This is the first pass metabolism. A drug you are giving, metabolism occurs, and the dosage of the drug is reduced before the drug enters the systemic circulation. This is your first pass metabolism. This is just to show you. This is the yellow card system. And I don't know how many of you are actually working in UK right now, and people who are in UK, they know this very well. Okay. And it just has a yellow card system. Any drug with suspected adverse drug reaction, you have to note it down. Okay. You have to note it down. This is your yellow card system. Okay, this is the yellow card for you. You can just take a look at it if you want. Nobody's going to ask you all the parameters in the yellow card, but at least know there is a system in NHS that's called a yellow card system. You have to note it down. All right. Now, some of the adverse drug reaction. Okay, this is called Gel-Coombs classification. Okay, there is a type 1, type 2, type 3, type 4. These are all hypersensitivity reaction. Just a revision for you. Okay, this has been asked again in your examination, so I have to bring the concept here. Type 1, I hope all of you know, this is IgE mediated reaction. It immediately occurs after administration because IgE immediately release this, for example, an anaphylaxis, an urticaria, an angioedema, or a bronchospasm. Immediately that occurs. Most commonly, this occurs secondary to antibiotics. We will see antibiotics. We will see which antibiotics has this effects. Number 2 is going to be your cytotoxic reaction. What they will ask to is mediated by which antibody. You should be knowing IgG mediated cytotoxicity. Okay. This targets your erythrocytes, platelets, hematopoietic precursor cells, anything. It can result in cytopenia and vasculitis. Where it occurs, heparin. I hope all of you know HIT. Heparin-induced thrombocytopenia. We are going to see about HIT. When we are going to see heparin, we are going to see the difference between HIT1 and HIT2, everything. Okay, no need to worry. Again, methyl dopa cause type 2 hypersensitivity reaction. They may ask you even in this way. For example, quinidine cause what type of hypersensitivity reaction? They can give type 1, type 2, type 3, type 4. They can even give type 5 also. You should be able to know that. All right. Then penicillin, again, type 2. Then comes the immune complex mediated reaction. Here, an antigen and antibody form a complex. That complex is called immune complex. All right. This is more seen in case of a serum sickness and vasculitis. Serum sickness is obsolete now because we are no more using this horse serum and rabbit serum and all much, because we have much more efficient synthetic protection of drugs. All right. Then this can occur in thymoglobulin, anti-thymocyte globulin. This we are not using anymore. Some old form of penicillin and procainamide, it can occur. Then type 4 is your cell mediated. Type 4 is always cell. Which cell is your T cell mediated? Okay, it's a T cell mediated that affects the skin. Okay, that affects the skin. Here, what happens? Most topical agents can lead to your type 4 cell mediated reaction, like your neomycin, corticosteroids, sulfonamide, and any beta lactams. All this can cause type 4 reaction. Just a gist, I hope all of you know what is a type 1. It's an immediate IgE mediated reaction. It's most commonly due to antibiotics, know that. And cytotoxic reactions are called type 2. Heparin is an example for type 2 cytotoxic reaction. Just don't forget methyl dopa, quinidine, and penicillin. Again, penicillin can cause both type 2 and type 3 as well. Type 3, again, A formation of immune complex, thymoglobulin, we are not using that much these days, and penicillin and procainamide is another example. Type 4, mostly topical agents and sulfonamides and beta-lactam. I hope all of you are clear with the classification and how it occurs and what are the common drugs that are involved in this. Then comes to the concept of orphan drugs. This they had asked again in the past. What is an orphan drug? Who do you call an orphan? Very unfortunate. We don't call anyone just like that as an orphan. Orphan is someone who lost either parent, either father or mother. We call them as an orphan. What is an orphan drug? These are the biological drugs. These are the drugs that are produced for rare and rarest of rare disease, which is not oftenly seen in a general population. That's called orphan drugs. Okay, rare diseases. Rare diseases. Why they are called orphan drugs is to manufacture and market the drug, tremendous amount of money is going to be required. Tremendous amount of money is going to be required to manufacture and market this drug. So this is called orphan drugs. I want you to know certain orphan drugs because they had asked like this, which of the following is an orphan drug? Or they may ask the drug name and they may ask you for which this is licensed to treat. Okay, for example, they can ask something like, sacrosidase. It's used to treat congenital isomaltase deficiency. Just to know at least few out of this because they can ask you in MCQ. Okay, these are called orphan drugs. Anagrelide you are using for essential thrombocytopenia. Imatinib mesylate, GIST, and as well as your CML we are using imatinib mesylate. I hope all of you know what is an imatinib mesylate. Okay, it's a tyrosine kinase acting drug. Okay, it cross-links between the chromosome number 9 and 22. All right. For Gaucher's disease, there is a drug called miglustat. This has been asked in your MRCP exam. Okay. There are two drugs for Gaucher's. One is miglustat, another is imiglucerase. And miglustat has been asked in your MRCP exam. That is the reason I brought. Every slide I brought here is the concept that has been tested for you. And Fabry's disease, again, agalsidase. And again, mucopolysaccharidosis type 1, there is an orphan drug called laronidase. And hereditary tyrosinemia, there is an orphan drug called orphanidine. These are some of the drugs. You don't need to know everything. At least know what is meant by orphan drug. Okay, and have a suspicion, some strange rare name. If they ask you an MCQ, try to mark it because it's impossible nearly to know all the name of all these drugs. It's absolutely impossible, but at least know what it is and know how to figure it out among the options. All right, now comes to another concept called the concept of plasma protein binding. Okay, most drug possess some kind of affinity for the plasma protein. Okay, most drugs, any drug that goes into your body, it's going to have some affinity or some affection or an attraction towards the plasma proteins. Okay, they get reversibly bound to this. All right, and always know acidic drug typically binds to plasma albumin and basic drug binds to alpha-1 acid glycoprotein. That's a very important point. Okay, acidic drug binds to albumin and basic drugs bind to alpha-1 acid glycoprotein. Why I'm telling is they had asked once the following drug binds to albumin. They given I think 4 basic drugs and 1 acidic drug. You should be able to mark it right. Okay, and increasing concentration of the drug can progressively saturate the binding sites. Okay, if you're giving more and more drug to the same thing, there is a binding site for any drug. It's a binding site, and this is going to be drug. If you give one drug, it's fine. Okay, but if the receptor take like this receptor has 4 binding sites. If you're giving one drug, okay, it will go and bind here. If you're giving 2 drugs, it will go and bind here. If you're giving number 3, okay, fine. Number 4, you can find. If you're going to keep on giving more and more drug, the binding site will be completely saturated. All right, the binding site will be completely saturated. The higher degree of protein binding generally make the drug long acting. If you want to make a drug to be long acting, it should be protein bound because it's going to keep on being in the circulation. It's going to keep on being in the circulation. Okay, that's why it is going to be long acting because the bound fraction is not available for the metabolism. Since it is bound to a protein, body cannot easily metabolize the drug. Okay, instead of the drug walking normally, this drug will bind to protein. It is like the drug going in a vehicle. Okay, the drug going in some vehicle. This vehicle is called protein. Okay, normally if the drug goes, it can get metabolized, it can get easily destroyed by the body's metabolic system and get excreted. But when the drug is going in a protein, it can evade that and it can keep on going in the circulation more and more. That is why the drug concept of protein, plasma protein binding is very important. Okay, now drugs with high plasma protein binding, I know this is a boring thing. Again, you have to know this drugs. There is nothing you can do. They had asked in an MCQ. All right. Yeah, that's a kind of carrier protein. So they had asked in the MCQ. So I don't have basically much mnemonics for you. I hope one or the other way you can discover your own mnemonics too. All right. To albumin, barbiturates, benzodiazepines, NSAIDs, valproate, phenytoin, penicillin, sulfonamide, tetracycline, tolbutamide, warfarin, all these things, because all these things are what drugs? These are acidic drugs. They can ask you in the other way around, which of the following is an acidic drug? Like I said already, what I said, plasma albumin typically binds with the acidic drugs, and acid, alpha-1 acid glycoprotein binds to the basic drugs. Yes, Dr. Atul, very dry subject. That's the reason we have to go through this. There is no other way. Okay, just for part 1, part 2 pharmacology will be slightly different, more clinical. Alpha-1 acid glycoprotein, again, alpha-1 acid glycoprotein, it binds to the basic drugs. Basic drugs are your beta blockers, bupivacaine, lidocaine, all these anesthetic agents, right? All the disopremide, imipramine, methadone, prazosin, quinidine, verapamil. These are all basic drugs. These are all basic drugs. All these basic drugs binds to your alpha-1 acid glycoprotein, where these acidic drugs will bind to your albumin, right? That you should be knowing. And some other thing you need to know, which drug concentrated in different tissues. If you're interested, just note it down. Okay, the slides are available for you. You can just open the slide on the website and you can note it down. They had asked once in MRCP-1 MCQ, which drug concentrates more on the bone and teeth. This is a huge list, huge list. Obviously, thyroid iodine, okay, digoxin and chloroquine, amitinol can go to kidneys, and chloroquine, again, it can go to liver, and tetracycline has affinity to liver. But what they had asked is, which drug has a high affinity to bone and teeth? Tetracycline. Okay, tetracycline, and heavy metals, and as well as bisphosphonate. Okay, among the option, they gave 4 different drugs and they included tetracycline. Okay, they included tetracycline. So this has a high affinity to bone and teeth. They had asked. Again, they may ask any other drug anytime. Okay, thiopentone. It's a potential question. They can ask. Thiopentone has a highest affinity to the adipose tissue. Again, minocycline, phenoxybenzamine, all these drugs has higher affinity to the adipose tissue. All right. And other drugs like liver and kidney, and here the retina, chloroquine. Okay, chloroquine binds to retina, and that's the reason chloroquine causes what? Bullseye maculopathy. Okay, it can cause retinal inflammation, it can cause visual disturbance. Okay, it has a high affinity to the retina. Typically, it binds to the nucleoprotein. To iris, ephedrine and atropine can bind to iris. Melanin pigment, it can bind to. These are different drugs concentrated in different tissue. Now come to the very, very important concept of the clinical pharmacology, that is your biotransformation. Everything is important. What is a biotransformation? This biotransformation means chemical alteration of the drug. Okay, chemical alteration of the drug. Okay, what happens? Drug typically comes as a soluble form. Okay, it's needed to render non-lipid soluble form to lipid insoluble, so that they are not reabsorbed in the renal tubules and excreted. Okay, drugs can be easily soluble and it can be easily get excreted into your renal system. Your kidneys can easily trap the drugs and excrete it out. So to render it lipid insoluble, that is lipid insoluble, so that it cannot be easily captured by the kidney and thrown out, a process occurs. That process is called biotransformation. This is very important. The biotransformation has 2 reactions, that is phase 1 reaction and phase 2 reaction. Phase 1 reaction is called a non-synthetic functionalization reaction. Okay, here a functional group is generated. Example, a OH group, COH group, or CHO group is generated. Okay, and It can be a metabolite, active or inactive. That's the phase 1 reaction. I'll tell you again what is the phase 1 and phase 2 again. This phase 2 reaction or your synthetic and conjugation reaction. Okay, here a drug will get conjugated to another drug. Okay, glucuronide conjugation, for example, all the bilirubin, biliverdin, all these things undergoes your glucuronide conjugation. Okay, again morphine and sulfate conjugate of minoxidil are active. Again, lot of drugs undergoes this conjugation reaction that are phase 2. I'll come to it in a minute. Okay, I'll come to it in a minute. And one more table I want you all to understand is the concept of prodrug and active drug. Okay, through the biotransformation, this prodrug will become an active form. I hope all of you know. Again, they had asked this in MCQ, which of the following is a prodrug? They may give anything out of it. Okay, anything out of it. They may give levodopa is a prodrug. Active form is going to be a dopamine. Enalapril is a prodrug. Active form is enalapril. Alpha methyl dopa is a prodrug. The active form is alpha methyl norepinephrine. And dipivefrin is a prodrug of epinephrine. Proguanil, the actual active form of the proguanil is cycloguanil. All right. Prednisone, the active form is prednisolone. Clopidogrel, active form is thiol metabolite. Vacampicillin, the active form is ampicillin. Sulfasalicylin, I hope all of you know, 5-amino salicylic acid is the active form of the drug. And then again, cyclophosphamide, the active form is aldophosphamide. All right. And fluorosyl, 5-fluorouracil, the active form is fluoride monophosphate. And mercaptopurine, methyl mercaptopurine and ribonucleotide is the active form. Acyclovir, they had asked again. The active form of acyclovir, they had asked in MRCP part 1. The active form of acyclovir is acyclovir triphosphate. Okay, this much you know. There is more list is there. If you want to note it down, you can note it down. I'm not going so deep into it now, okay, because I'm going to start with the biotransformation now. Then we are going to go into the systemic pharmacology. Okay, you should know in the biotransformation subject. So whatever we give, it's a prodrug. Not every drug is a prodrug, an active drug. Okay, some drug can come in active form. Okay, but certain drugs we do give as a prodrug. Okay, you should know which drugs are they, because they had asked twice. They had asked twice. So this left side of your table is very important. You should be knowing this. Or for a change, they may ask this. Which is the active form of what? All right. So in the biotransformation, I told you phase 1 and phase 2 reaction. We will go into that. Before that, there is a concept of enzyme inducers and enzyme inhibitors. This again, they had asked. They may ask clinically as well. What are the inducers? Inducers are the drug. Enzyme inducers are the drug that goes and induce the metabolizing enzymes. Okay. As a result, what happened when the enzyme is induced, the actual thing which can go ahead and cleave and excrete the drug is induced, the actual effect of some other drug which is already in the body will be decreased. Okay, the efficacy will be decreased. These are the enzyme inducers. On the contrary, there are enzyme inhibitors. This drug goes and inhibits the action of certain enzymes. As a result, what happened? The enzymes that is required for clearing the drug is decreased. As a result, what will happen is drug toxicity occurs. All right, you should all be knowing what are the inducers and inhibitors. This table is very, very, very important. Okay, inducers are your phenobarbital, rifampicin, carbamazepine, phenytoin. Big list is there, at least know this. Okay, this 4 is very important. Phenobarbital, rifampicin, carbamazepine, and phenytoin. These 4 drugs, don't forget. PRCP, PCRP, whichever mnemonic you want to follow, you can follow. Inhibitors, again, this is important. Cimetidine is an enzyme inhibitor. Isoniazid is an enzyme inhibitor. Fluoxetine, erythromycin, ketoconazole, known for enzyme inhibition. It can rise the toxicity of many other drugs, which we are going to see in the MCQs and when we are going to see ketoconazole. Ritonavir, isoniazid again, and grapefruit juice. This is a potent enzyme inhibitor, grapefruit juice, and we are going to see about cranberry juice. This grapefruit juice can interfere with your statins, which we are going to see when we are going to see about statins. So these are the enzyme inducers, enzyme inhibitors. This table is again very important. They had asked on this. They will even give a clinical scenario and ask the toxicity of this drug is due to what drug. I will explain you when we are going to come to the clinical scenarios. And this is your biotransformation. This is very, very important. Phase 1 reactions. They had asked once, what are the phase 1 reactions? Even if you don't know what exactly is happening in phase 1 reaction, all these things, at least know the title. That's what I can ask you to do. At least know there is something called oxidation. You know what is an oxidation, you would have read. Okay. Oxidation is what involves addition of an oxygen. That's one of the phase 1 reaction. Reduction. What happens? Converse to oxidation. It just goes opposite. It just reduces an oxygen. What happens? Which are the drugs involved in reduction reaction? Your alcohol, aldehydes. Yeah, there is a nice mnemonic Dr. Jyoti has said. CRAPS GP, yeah, CRAP GP, sick faces. Yeah, you can use the mnemonics to remember that. Quinolones are reduced. Quinolones are reduced. All these drugs, alcohol, aldehyde, quinolones, all are reduction. What they may ask you is, they may ask you which of the following drug undergoes a reduction reaction. At least know 1 or 2 examples. Okay. Drugs primarily, other drugs that can reduce are your chloral hydrate, chloramphenicol, halothane, warfarin. All these drugs undergoes a reduction reaction. Then hydrolysis. Hydrolysis. What is hydrolysis? Cleavage of a drug molecule by taking up in a water molecule. Lysis means destruction, cleavage. Hydro means water. Hydrolysis, they are taking the water and cleaving or destroying some of the drug molecule. And cyclization, that is changing in the ring structure of the compound. For example, cycloguanyl and proguanyl. The name itself says cyclo. Cyclization is occurring here. Decyclization is the removal of the cyclic ring that is seen in your phenytoin typically. Even if you don't know everything inside, please know a few things. Phase 1 reaction, oxidation, reduction, hydrolysis, cyclization, and decyclization. Okay, at least know the names. At least know the names. Okay, then rest, even if you don't know, that's not, at least know the names. What are the reactions that is happening in phase 1? Now comes to phase 2 reaction. Phase 2 reactions are more important because they had asked about glucuronate conjugation twice or thrice. Glucuronate conjugation is a very important reaction. It is carried out by the enzyme called UDP glucuronyl transferases. These UGT groups are very, very important. Okay, very, very important. What happens in the phase 2 reaction, how it occurs is the compound with a hydroxyl or a carboxyl acid group is easily going to be conjugated. If this is a compound with a carboxyl or a hydroxyl group is there. Okay, this will get conjugated with your UDPG or UGT enzyme, anything you can call it. This will get conjugated, this will get connected with this. So which drugs goes through this? At least you don't need to remember this drug name, at least know the drugs which are undergoing phase 2 glucuronate conjugation reaction, that are your chloramphenicol, your aspirin, your paracetamol, your diazepam, your lorazepam, your morphine, and your metronidazole. At least know the names of this drug. This they will ask you. Then comes another reaction called acetylation. What is an acetylation? Again, adding an acetyl. Okay, with an acetyl coenzyme, the drugs are metabolized. There's a huge list of drugs, your dapsone, your hydrolysine, your clonazepam, all these drugs acts on them. In this, the main important things are, there are 2 kinds of people. One group of people are called fast acetylators, and another group of people are called slow acetylators. If somebody is going to be a slow acetylators, and acetylators, they are going to be at the risk of certain things. Fast acetylators are going to be at the risk of certain things, which we will see soon. Okay, this is phase 2 reaction. At least in biotransformation, make sure you know the names of the synthetic phase 1 non-synthetic phase 1 reaction, and names of the synthetic phase 2 reaction, that is glucuronate conjugation and acetylation. Please make sure you know the drugs that are undergoing glucuronate conjugation. Okay, that's important. Then the other reactions are your methylation and sulfate conjugation, glycine conjugation. Again, all these things can occur. I think this has been duplicated. Methylation, again, adding a methyl transferate group. Okay, all this adrenaline, histamine, nicotinic acid. The name itself, that's why we call it as a methyl dopa, alpha methyl dopa, captopril, mercaptopurine, all these things undergoes methylation reaction. Then comes sulfate conjugation. Here, what happens? Compounds such as your phenolic compounds and steroids, all this will be sulfated. A sulfate group will be added to it. Here, chloramphenicol, methyl dopa, adrenal, and sex steroids can go through this pathway. Then glycine conjugation, this is not a major metabolic pathway. Just know the names here. Only for glucuronide conjugation, I want you all to know the name of the drugs because they are likely to ask you. Then glutathione conjugation, this is another important thing because glutathione is now a topic of interest for so many researchers. All right, there are a lot of drugs coming in the name claiming to replenish the glutathione we have lost. Okay, there are a lot of drugs coming like that. So glutathione conjugation is very important. Okay, this is carried out by glutathione S transferase. Okay, this forms a mercaptolate. Okay, this is very, very important. Though this is a minor pathway, just know the name. One such drug that has been implicated in this, your paracetamol. You will know when we are going to study paracetamol poisoning and N-acetylcysteine and why it is very important in the paracetamol toxicity management, how it goes and replenishes your glutathione. Glutathione is one of the very wonderful natural antioxidant in the body. So glutathione conjugation, at least remember the drug paracetamol. Okay, then ribonucleoside nucleotide synthesis pathway is not that much. This is for your purine and pyrimidine antimetabolites that is used in your cancer therapy. Know this glutathione conjugation and know about glucuronide conjugation. That's very, very important. Okay, now comes the drugs and the metabolizing enzymes. This can be absolutely boring. Okay, this can be absolutely boring. Just I'm giving the table. You don't need to know everything, but they had asked a couple of questions based on this. CYP1A2 metabolizes which drugs? Okay, and it's inhibited by what? You don't need to know everything, but I will just mark what they had asked previously. CYP2C8 they had asked. Paclitaxel and your rapaglinide, both the drugs acted on by that. These are the inhibitors of the drug. And one more thing they had asked, the CYP2C9 is their favorite. Again, they had asked, these are the list of drugs that is acted upon by CYP2C9. Just note it down. Even if you can't memorize everything, at least know one or two drugs based on this. Then this has been asked again, especially this is related to your omeprazole. So they had asked, omeprazole is acted on by which enzyme? They had asked previously. They had given the options of CYP2C9, CYP2C19, and CYP1A2. They gave all the options. So CYP2C19, omeprazole is the drug that is being acted upon by that. At least know this. Even if you don't know these two columns, it's perfectly fine. At least know the substrates. At least one or two out of everything, you note it down in your pharmacology notes. That should be more than enough for you. And CYP2 D6, there is a huge list, at least know one or two drugs out of it. That's all. And CYP2E1, they had asked, and most of your anesthetic agent, at least remember that, most of your anesthetic agent, the gases CYP2E1, at least note it down like that. Anesthetic agent CYP2E1. Your sevoflurane, isoflurane, haloflurane, enflurane, all fluorines are CYP2E1. At least remember that. CYP3A4, this is the most common. If you can note down all the other names, the rest of the drug, whatever they ask, you can just mark it as CYP3CF, CYP3A4. This metabolizes most enzymes. CYP stands for cytochrome. This most drugs, most rest of the drugs are going to be metabolized by CYP3A4. All right. This is how a prescription looks like. Classical prescription from NHS. This has been changed a lot. This is a classical one. And people who are working in UK, they have different prescription pattern for different trust groups. This is a classical one. Okay, this is how they do drug, what has to be taken, and handwritten doctor. They will take it to clinical pharmacologists. They'll be able to choose the proper brand for them. All right. Then comes the first pass metabolism. This I already told you how drugs are going and then get metabolized. And now comes to some of the mnemonics I have added for you. This is the drug with very high first pass metabolism. This you should be knowing. The mnemonic is nil by mouth till we say. Okay, just remember that, nil by mouth till we say. These are the drug with very high first pass metabolism. They had asked in MCQ for MRCP-1. That's why I pulled this up. Nil by mouth till we say. Nil, N for nitrate, I for imipramine, L for lignocaine, B by for beta blockers, morphine, testosterone, verapamil, and salbutamol. These drugs has a very high first pass metabolism. All right. Don't forget the mnemonic, nil by mouth till we say, nitrate, lignocaine, beta blockers, morphine, testosterone, verapamil, and salbutamol. These drugs has a very high first-pass metabolism. Note it down. That will help you. Now comes the clearance of a drug. What is a clearance of a drug? What is meant by the word clearance? Clearance is how fast the body can clear a drug off from your body. Clearance of a drug is theoretical volume of plasma from which the drug is completely removed in a unit time. At a particular time, how much of the drug is cleared off? Okay. Clearance formula is going to be rate of elimination by C. C is the plasma concentration. Cl equal to rate of elimination by C. This is the plasma concentration and Cl equal to clearance. They had asked once one calculation they had asked, what is the clearance of the following drug? They had given the rate of elimination and they had also given the plasma concentration. All you have to do is sit there and divide and mark the right answer. Unfortunately, I think you cannot take your calculators inside the exam hall, especially. So you have to know some basic mathematics and division and addition. And I would suggest if you're seeing a mathematics question, it is absolutely confusing you, just mark it and leave it and work out all the other question and come for that. Please don't spend a huge amount of time unnecessarily working out any calculation which is just actually confusing you, and don't waste the time and don't lose other questions which can actually boost your marks. Okay. And now comes to the first order kinetics and zero order kinetics. This is very, very important. There have been MCQs asked on this. What is the first order kinetics? First order kinetics is nothing other than the rate of elimination of any drug is proportional to the drug concentration. Whichever amount of drug is there, proportionally it get eliminated. Okay, the clearance will remain constant. It means at 1 hour, this much drug is eliminated, and the first hour, a constant amount of the drug will be eliminated, and the second hour, again another constant amount of drug, third hour, again another constant amount of drug will be eliminated. That is the first order kinetics. Okay, first order kinetics. That's why they say constant fraction of the drug present in the body eliminated in unit time. Properly it will be eliminated. Okay, just imagine it's like a airplane once it's landed. Okay, airplane once it's landed, there are certain airliners, they are very disciplined. Okay, they will tell number 1 to 20 first you guys can go through the front door or through the aero bridge, or you can use the ladder. There are certain airlines, they just open all the doors and people will go on, barge on, pull the bags, and they will make sure the bags hit the fellow passenger and their head will hurt and there will be a lot of commotion going on. People just pushing, pulling each other and going through the exit door. Okay. First order kinetics is like a proper airliners who will just open the door and they will allow set amount of people at the set amount of time to exit through the proper door. There is going to be another kinetics called zero order kinetics. Okay, irrespective of the drug concentration, elimination occurs. It is like a worst airliner. You can imagine, just imagine some worst airliner, they're just opening doors and not announcing anything. Now the passengers can exit in any way they want. They will exit through any random door, pushing and pulling and dragging their luggages and hitting other passengers. That's what your zero order kinetics. All right, you should know some drugs which acts through the first order kinetics and which acts through the zero order kinetics. Okay, that you should know. This is the first order kinetics. See, a constant proportion of the drug is eliminated properly. I gave an analogy of an airplane, how the passenger exits. So the drug comes, it exits systematically in unit time. That is the first order kinetics. Just to know the graph, you don't need to confuse so much about by DC, by DT, and half-life, everything. Half-life concept, I will explain. This is your zero order kinetics. Here the drug, just like that, it gets eliminated. It doesn't matter how much amount of drug is there in the body. One example for zero order kinetics is your ethyl alcohol. Your alcohol goes through a zero order kinetics. All right, I'll tell about that. Okay, then comes your plasma half-life. Plasma half-life is the T off, they call it as a T off. When, what is it? Simply, you can understand. This is nothing other than the drug, time of the drug, time taken by the drug to reduce half of its plasma concentration. For example, you are giving a 300 milligram drug. What is the time that is going to be taken for this drug to become a 150 milligram? This is your plasma half-life. right? It has two phases. First phase is rapidly declining phase due to distribution. Then the steady place, that is your elimination phase. Just know these 2 points. That's more than enough. Know what is a plasma of life. All right. And different type of inhibitors and inhibition. I don't think this they will be needed for you. But still, I'll just see. Something is obscuring my screen. Yeah. Just a second. Yeah. There are two types of inhibition. They haven't asked, but I just added for the completion's sake, competitive and non-competitive inhibition. Competitive inhibition is nothing but the inhibitor that resembles the substrate. Okay. For example, this is a receptor. For the receptor has a substrate. Okay. For example, you can take it as this is an insulin receptor, and the substrate here is going to be your insulin. Okay. What is a competitive inhibitor? Is the whatever sub inhibitor is coming, that will resemble exactly like the insulin, and it will go and take its place. That is the competitive inhibitor. Non-competitive inhibitor has no resemblance of that. Okay. Have you heard the word called a doppelganger? What is meant by the word doppelganger? Doppelganger is someone who exactly resembles the person. If you carefully see across the world, there will be at least 5 to 6 people who will resemble your facial appearance and your looks. That's why people say, oh, you exactly look like him. You exactly look like her. That is what we call as a doppelganger. So something like that, when the substrate actually resembles like the drug and takes the substrate's place, it's called competitive. When it doesn't, it's a non-competitive inhibition. Okay. Here the inhibitor binds at the active site. Whichever is the active site of the receptor, the inhibitor will go and bind. Here the inhibitor will bind at the site other than your active site. Okay. That's the second thing you should be knowing. Then thirdly, the enzyme binds either with substrate or the inhibitor. Here the enzyme will bind both to the substrate and inhibitor. Both are reversible form of inhibition. Okay. This can be overcome by increasing the substrate concentration. This cannot be overcome by increasing the substrate concentration. Anything competitive, if you're going to keep on increasing the drug dose, it can be overcome. But in a non-competitive inhibition, even though how much ever you are going to increase the dose, it's not going to be of any help. This is just for completion's sake. I just added. Now comes to the agonist. This has been asked in MCQ. They had asked some examples, and they asked, is it a full agonist or a partial agonist or an inverse agonist? Everything I'm going to explain you. Okay. Of course, another 30 minutes of dry general pharmacology is going to be there. After that, once we go to the systemic pharmacology, it can be a little bit more interesting. Okay. Now comes to the first thing is a full agonist. What is a full agonist? Okay. It binds to the receptor and produces the desired effect. Okay. It many times resembles the endogenous ligand. What is an endogenous ligand? Okay, I hope all of you know what is meant by a receptor. Okay, endogenous is something that is produced in your own body. Okay, for example, phenylephrine. Okay, phenylephrine is that you are giving the drug phenylephrine. Okay, maybe for a cough or anything. It goes and binds to the alpha-1 adrenoreceptor, and it acts in the same way how an adrenaline acts. All right, that's what you call as a full agonist. It acts in the exact same way. Partial agonist, the name itself says they have an efficacy greater than 0 but lesser than that of a full agonist. It again goes and binds the partial agonist, but it won't be as good as your full agonist. For example, aripiprazole is an atypical antipsychotic we use in schizophrenia. That's partial agonist. Number 3 is the concept of inverse agonist. What is an inverse agonist? Inverse agonist binds with the constitutively active receptors, stabilize them, and reduce the activity. Negative intrinsic activity. These drugs will go and binds and produce a pharmacologically opposite action. This is the receptor. This drug goes and binds to the receptor, but it won't produce the desired pharmacological action, but it will do something totally opposite. For example, all antihistamines acting at H1 and H2 receptor shows inverse agonism. Know the names. This is very important. They had asked which drug shows inverse agonism. You should be knowing. Again, another easiest example for all of you. What is an antagonist? It binds to the receptor but does not produce any effect. It just goes and sits and just occupies the space. That's an antagonist. Agonist, it goes and binds to the receptor and fully activates it. Okay, courtesy to nonstopneuron.com, I had asked the permission and took the picture. And then comes the inverse agonist. Inverse agonist binds to the receptor and it inhibits the intrinsic activity. And there is something called partial agonist. Partial agonist, name itself says, partially it has some agonistic action. It binds with the receptor and activates it partially. That's what we call as a partial agonist. And a couple of more concepts before we go to systemic pharmacology. The concept of LD50. LD50 is nothing other than median lethal dose. The dose of the drug that produces death in 50% of the animal population tested. That is LD50. At what dose, if you're going to give, typically they're going to test in guinea pigs. And what dose the drug is going to cause death of 50% of any animal population is called your LD50 or your median lethal dose. The other concept is your ED50. ED50 is the dose of medication produces a desired pharmacological effect in 50% of the studied patient population. For example, you are going to take a drug to make a drug to reduce tachycardia. Or maybe you're going to, for example, we are taking, even yesterday I had a case, atrial fibrillation. The patient is presenting to you. Acutely, you are going to give some short-acting beta blocker like esmolol to reduce the rate. Okay, the ED50 is like at what level 50% of the population with atrial fibrillation will have the heart rate reduced. That is what is called as your ED50. Okay, at what level any drug will have its desired effect. Esmolol's desired effect is what in an atrial fibrillation? To decrease the heart rate. So at what level this produce as a decreased heart rate in 50% of the population? That's what we call as a ED50. All right. Then therapeutic index. Therapeutic index is very important because a lot of MCQs came along with the therapeutic index in the clinical pharmacology. Therapeutic index is the blood concentration at which the drug becomes toxic. For any toxicology, therapeutic index is very, very important, especially for toxicology, at concentration which the drug becomes toxic, the concentration which the drug will become very nasty. Therapeutic index can be calculated by toxic dose and dose of the therapeutic response. That is your TD50 and your ED50. All right, this is your therapeutic index. And then drugs, we should do some therapeutic drug monitoring. This has been asked in MCQs again. These are your aminoglycosides. Again, you have to, especially gentamicin, amikacin, and tobramycin, you have to do therapeutic monitoring because it can cause nephrotoxicity, it can cause autotoxicity. So you have to do TDM, therapeutic monitor, TDM. They will ask which drug you should do TDM. There is no excuse. You should be knowing these drugs by heart and knowing the adverse effect by heart. We cannot get away from here. Anticonvulsants like carbamazepine, phenytoin, phenobarbital, sodium valproate, all these drugs needs TDM again. These drugs needs to be therapeutically monitored. Why? They cause neurological toxicity, but also cardiac and respiratory toxicity as well. Then digoxin, it can cause cardiac toxicity. It needs therapeutic drug monitoring. Lithium, again, therapeutic monitoring is needed. Methylxanthines like theophylline, it can cause tachycardia, convulsions. You have to do that. Vancomycin, again, you have to do TDM because of nephrotoxicity and autotoxicity. All right. Now comes the definition of class of drugs and their efficacy. How efficacy and how good the drug, adverse effects. TDM is therapeutic drug monitoring, doctor. That's what I said. TDM, therapeutic drug monitoring. It's mentioned over here. Okay, but I hope that helps. All right. Now, they all would have mentioned this thing, okay, class of drugs like pregnancy class A, pregnancy class B, pregnancy class C, pregnancy class X. What is this class? Adverse effect classes. This again, you guys should be knowing. Class A drug, okay, class A drug. What is a class A drug? It's an adequate, well-controlled trials have demonstrated no risk for the fetus. You should be knowing this very well. Class A drug means no risk for fetus. Class B, no evidence of risk of female fetus exists, although adequate and well-controlled studies have only been carried out in animal. These are the drugs. Maybe they would have tested in some guinea pigs or hamsters or anything that it has no adverse effect on their fetus, but no evidence of risk to human fetus exists, but the studies are not well carried out in human beings. Thus are called category B drugs. Okay, category C drugs, animal studies may show risk of harm. For example, you are going to take the drug and test it in an animal. It may show some harm to the animal's fetus, but the study has some lack of adequacy in animals or in humans. Okay, but here these are the drugs where the benefit may outweigh the risk. Okay, where the benefit outweigh the risk, the drug can benefit more than what the risk that drug carries. Those are called category C drugs. And category D drugs, evidence of human risk does exist. Through study and post-market research, it can harm the fetus. But still, benefit of using may still outweigh the risk. We may use it if it has more benefits than risk. It depends on different scenario. We can come to a conclusion. Category S is X means X, no. Clear evidence of risk to fetus and the risk outweighs the benefits. Here, this is the drug. You are not going to use it pregnancy at all. They are contraindicated in pregnancy. That's what you call as category X. All right. I hope you all know A, B, C, D, and X, what it is. Now comes to clinical trials. I hope all of you know this. Just for completion's sake, in preclinical trial, preclinical trial, here it's a laboratory research, typically determine the treatment is useful and safe in animal models. Now comes to phase 1. What happens in phase 1? Once the preclinical trial gets over, the drug gets approved for human testing. Phase 1, safety and tolerability of the drug and pharmacokinetics, PK will be monitored, and drug-to-drug interactions in a healthy volunteers. I hope you know, like a lot of people, they make money by becoming a volunteer for, drugs. During COVID, a lot of people just became volunteers for COVID vaccinations. All right, then phase 2, less than 100 people. Again, safety, tolerability, and intermediate term efficacy can be checked in phase 2. Phase 3, again, more than 100 volunteers they will pick. And again, the evidence showing the new treatment is safe and efficacious. Here, we just took an example of TB. We can put any disease. After the phase 3, the drug is approved by the FDA or any organization that is controlling the drug authority in that particular country, and goes for phase 1, where more than 1,000 people will be monitored and testing of long-term adverse effect in the diverse patient population across the age groups, across the races. We have to do that. Is your phase 4. This thing you would have definitely studied in your undergraduate. Still, I have to do it for completion sake. Now we are going to go and step into your proper systemic pharmacology. I know general pharmacology must be absolutely boring. Now from systemic pharmacology onwards, it can be a little bit more interesting to read and learn. And shall we take a break here? Anyone wants a break here? We can take a break for 5 to 10 minutes and we can begin systemic pharmacology. Is it all right? Okay, we can take a break. I know that's heavy on you. Please go through that again and take some notes on whatever I said. It's important, and go through them again, please. Okay, I don't want anyone to miss anything on clinical form. Okay, we will take a break for 10 minutes and we will get back again. Okay, yeah, sure. Back here, yeah, welcome back. Dr. Adia, Dr. Shahida, welcome all the doctors. Dr. Jodi, Dr. Faiza, Dr. Mohammed. I know general pharmacology can be absolutely dry, and some people can't help, right? I can straight away start with something clinical, but my conscience never allowed me to do that. Okay, it's an education, so education should be proper. So without teaching you all the concepts, just if I start away straight away starting AC inhibitors, okay, cough or something like that. If I'm gonna do cyclophosphamide, hematuria, okay, bladder irritation, give mesna, like that. If I'm gonna teach, it's not gonna make sense. So I want things to be little systematic. That's the reason. Welcome back, everyone. Dr. Mahmoud Sana, Dr. Wawais is back, Dr. Ashik. Yeah, chemistry and names are at fault. Yeah, I do agree, Dr. Jyoti. Yes. So that's the reason I wanted to teach like that. That's the reason we are having a 4-day class. Okay. So some of the things can be a little boring here. Of course, I told you, I gave a warning shot. All right. So try to listen. It's for your own good. Because if I wanted to keep a short lecture for 2-3 days, I can easily done that. But I just studied back pharmacology. I just contacted, I hope how many of you know, no, I don't know, who know Dr. Mas Chapunda. He is a clinical pharmacologist, plus he is a tropical medicine consultant. He's in pastist. Just had a word with him, like asked him what should I teach for these people, what are the topics I should sell. I mailed him like way back, and after nearly 1.5 months, I got a mail that based on suggestions from big time consultants, I just made this lecture so that it should be fruitful for every one of you. All right, without wasting much time, this is systemic pharmacology. All right, first is going to be a cardiovascular pharmacology. Of course, next 10 slides may be slightly boring. After that, we are going to go straight into the drugs. Certain properties of cardiac muscle you should be knowing because they had asked. All right, autorhythmicity. Okay, what is autorhythmicity? Name itself said autorhythm. It means it can automatically create a rhythm on its own. The ability to initiate a heartbeat continuously and regularly without any external stimulation. That's why automatically it's called autorhythmicity. Second property I want all of you to know is excitability. The ability to respond to a stimulus of adequate strength and duration. If any stimulus is given to the cardiac muscle, it can excite itself. It can propagate an action potential. That's called excitability. Then comes conductivity, the ability to conduct the stimulus from one cardiac tissue to other tissue. For example, from SCA node to AV node, it can conduct an impulse. That's called the conductivity. Then comes contractility, the ability to contract in response to stimulation. There's a reason why I put the slide. Okay. Then another 4 terms is very important. They had asked this 5 terms. Okay. They had asked, I think when I sat for part 1 somewhere around 2017, 18, 17. Yeah, that time they had asked us. Okay, first thing is going to be your inotropy. Inotropy is nothing other than your contractility. When I sat for exam, they asked me about lucitrophy. Chronotrophy. What is the chronotrophy? Rate of the SCA node. Rate at which the SCA node fires is chronotrophy. Dromotrophy is the conduction of the AV node. I hope all of you know the cardiac anatomy. Yes, this is your AV node, this is your SA node here. Okay, inotrophy is the overall contractility, chronotrophy is the rate at which SA node fires, dromotrophy, this is your chronotrophy, this is your dromotrophy. The conduction in the AV node is called your dromotrophy. Warmotrophy is the excitability of the cardiac muscle. Lucitropy is what they asked us. Lucitropy is what? It's a contractility or conduction, excitability. They gave all the options. Lucitropy is relaxation. Okay, so relaxation. Lucy, relaxation. Okay, now comes to cardiovascular pharmacology property. I hope all of you know. These we are going to divide into 5 different topics. And first is your antiarrhythmic agents, which is going to be a little boring, but we have to study because a lot of MCQs came around your antiarrhythmic agent. Number 2 is your antihypertensive agents. This can start from your nitroglycerin and all the way to calcium channel blockers, your aliskiren, hydralazine, everything we want to learn. Number 3 is your diuretics. Okay. And number 4 is your phosphodiesterase inhibitors like your milrinone and your sildenafil. Then other agents like digoxin and ranolazine, all these things. I am not covered so much, so advanced drug which has been recently came up. Okay, recently came up. Anti-angina medication, doctor. All this thing can also act as an anti-anginal medication. Okay, like nitroglycerin is an anti-anginal agent. Beta blockers you can give. Calcium channel blockers, again an anti-anginal medication. Okay, all these drugs we are going to learn together. Okay, and we are going to start with your antiarrhythmic agents, which is very, very important because angina you can even give morphine, you can give oxygen, all these things. Okay, all these drugs we are going to start. One by one, I'm going to start. First thing is your antiarrhythmic agents. Okay, before we start into antiarrhythmic agents, we need to know the phases of cardiac cycle at which different antiarrhythmic agents acts. This again can be a little boring. Bear with me. The phase 0 is the first phase. It's a rapid depolarization phase. I'm going to show you the picture. Okay, just hold on. Rapid depolarization phase. What occurs here is the fast voltage gated sodium channels open, leading to rapid inward sodium current. Here, the first phase, what happens is, the sodium channels open, and as a result, the membrane potential rises. And as a result of opening of sodium channel, what happens? Sodium channel starts coming into the heart in a rapid phase. That's a phase 0, rapid depolarization. Then phase 1, initial repolarization. Here what happens is rise in membrane potential that leads to inactivation of fast voltage gated sodium channels. The way it opened fastly, it will lead to inactivation closure. As a result of that, membrane potential will drop transiently due to also what happens here is potassium and chloride ions can transiently, they will keep trickling into your cardiac muscle. Then phase 2 is your plateau phase. They had asked which phase of the cardiac action potential is a plateau phase, is your phase 2 phase. Okay, here L-type voltage gated calcium channels open to allow the influx of the calcium ions. What happens initially, first an impulse comes, sodium channel will open. Sodium channel opens, as a result of that, the action potential will keep going up. Then suddenly sodium channel close, sodium ions will go out and potassium and chlorine will come. So there will be a phase of repolarization. Then again, to counteract this, calcium channels will come in. This is called plateau. Plateau means flat. So there will be a flat plateau phase will be there. Okay. Phase 3 is the rapid repolarization. The calcium channel which opened, okay, this will start closing down. This will start closing down, especially L-type voltage gated calcium channels close, while slow delayed rectifier calcium channels will keep remaining open. Thereby, there will be a rapid repolarization will occur in this phase. Okay. Number fourth phase is your resting membrane potential. It's around minus 85 millivolt. It's typically dominated by potassium equilibrium. I'll show you. Okay, these are the 4 phases. Okay. Phase 0, what happens? Your sodium ions will open up. Okay, sodium channel opens up. As a result, the action potential goes up all the way. Your action potential goes up. That is your phase 0. And next phase, what happens? The sodium channel closes and your chloride and your potassium channel happens. As a result, there is a dip. Then comes the plateau phase. To counteract that, what is happening to counteract that? To counteract that, what is happening is the calcium channels comes in. Then the calcium channel closes, it starts dipping. Okay, and potassium ions keep coming in. Then 4 is your resting membrane potential, which is around minus 85 millivolt. I hope all of you are clear with this concept, because this is very, very important, and none of you should go wrong with this kind of concepts, because they had asked a couple of MCQs on this. So you all should be aware of it, and you all should be ready to answer any questions that are going to be asked in this concepts. Okay. Which ion opens where, which ion closes when, this thing you should be knowing. No one should make any mistake in this. Okay, please remember, no one should make any mistakes in this. Always remember. Phase 0, phase 1, phase 2, phase 3, and phase 4. None of you should make any kind of mistake in this. This is the basic action potential. Okay, they will ask you in cardiac physiology also, cardiac electrophysiology also, in basic sciences. So that's the reason I had to brush this up again. Okay, all of you are clear? I'll go to the next thing. Now comes to latest classification of antiarrhythmic drugs. So your typical 4-class classification is over. Now newer classification has come, but I'm not sure whether they are going to ask you from the older one and newer one. In the newer one, they made little modification by adding new classes of drugs. Okay, they added newer classes of drugs. Still, I'm going to stick with the old, but for the people here who are advanced learners, I'm going to show you the newer classification as well. Okay, yes, got it. That's it, doctor. That's it. All right. Now class 0. Okay, the class 0 is your HCN channel blockers. Here they call it the drugs like your ivabraden as class 0 drug. This is a latest Vaughan Williams classification, not the typical ones which you are seeing anywhere. All right, not the typical classification. This is the latest classification, because sometimes if they may ask, I don't want, don't want anyone to miss this out. Okay, miss this out. HCN, I'm going to tell you next. That's the thing. HCN is, who knows what is a HCN? Anybody? Okay, I'll write hyperpolarized. Okay, hyperpolarized activated cyclic nucleotide channel. Okay, that's your HCN, hyperpolarized activated cyclic nucleotide. The latest classification starts class 0 as HCN channel blockers. Remember the drug ivabradine. Okay, the ivabradine, what it does, it inhibits IF, that funny currents. They had asked in MCQs. Ivabradine inhibits funny current and SCA node phase 4 pacemaker depolarization rate. Reduce the phase 4 depolarization rate. Thereby, it reduces the heart rate and also it decreases AV node and Purkinje cell automaticity and increases the RR interval. These are the actions of your ivabradine. What it does, class 0, they changed into ivabradine. Okay. This is the latest classification. Please don't anyone come and tell me it's not in past medicine notes. That's not a textbook. Okay, this I have taken from Braunwald Cardiology, latest update. I have taken, also verified this from European Society of Cardiology, also verified this from up to date. Okay, so there's never a chance it's going to go wrong. This IF, funny current inhibition, leads to 4 things. SC node phase 4 action potential will go down. Okay, SC node phase 4 action potential is going to go down. Heart rate is going to overall reduced. AV node and Purkinje, yeah, doctor, please type. Cells also will be decreased, and as well as RR interval. You can type the questions meanwhile. Whenever I'm seeing in the chat, I'll definitely answer the questions. All right. Example of this is your ivabradine. This is your ivabradine. Okay, it's used in what? Stable angina. Some other doctor asked about anti-angina drug. Yes, many of the drugs can asked in this stable angina. Potential new applications for tachyarrhythmia as well. All right. Therapeutic mechanism, like I said, it reduces the SCA node automaticity. Then class 1. Class 1, they have divided into class 1A, class 1B, and so on. Dr. Abdul, you can type your question. You are more than welcome. Please type your question. I'll be able to answer it. Okay. Class 1A are what drugs? Your quinidine, ajmalin, and disopramine. These are the drugs they added as class 1 in the latest classification. Class 1A especially. Please note down, this is the latest classification. All right. Now 1 point stay. Okay. You don't need to know everything. At least know the names of this. Okay. It's more than enough. Okay. And class 1B is your lidocaine and mexitulin. Okay. Class 1B is lidocaine and mexitulin. You should know the next column, that is the application of this. I'm sorry, this is coming in between, so I am just dragging it around. Okay. Class 1A you use for your supraventricular tachyarrhythmias, okay, particularly recurrent atrial fibrillation, ventricular tachycardia, and ventricular fibrillation, including your Brugada syndrome. Lidocaine and mexitulin, again, it can be used in ventricular tachyarrhythmias. I hope all of you knows. Now comes to class 1C drug. Okay. Again, I have to drag it. Class 1C is due to reduction of the sodium current, and the drugs, at least you know, propafenone and flecainide. I hope all of you know flecainide. Flecainide is called as pill in pocket pill for your atrial fibrillation. It's used in all supraventricular tachyarrhythmia, especially atrial fibrillation and atrial flutter in a healthy heart. In a healthy heart, yes, PIP. Okay, Dr. Abdul. A lot of questions in past medicine are according to the notes. For example, cardiac catheterization, left or right values are different than your lecture. Doctor, my lecture, there is nothing I'm putting my notes. It's from either NICE, SIGN, ESC, and up to date, those stuffs. If you have a doubt, you can do one thing. You can go and verify that with a textbook or an authenticated source. That will be completely different. Cardiac catheterization, left or right or oxygenation values are different. Yes, of course it is. Because basically all our lecture, they have given question according to the rules. Of course, because past medicine is written by MRCP Part 1 pass and MRCP Part 2 freshly passed people. You can also write a question. They will give you, I think, $10. You can write just anything. They will give you money. They'll give you money. Seriously, I'm telling, they'll give you money. Attempted, they got wrong. Okay. Always, that is the reason I'm just giving all my slides. Everything is evidence-based. Nothing like I'm just blabbering something or taking out on something and showing. It shouldn't be like that. Whatever I'm giving you, it should be of high quality based, evidence-based things. And what they follow in UK and what we follow in. That's the reason we are taking a lot of efforts. Otherwise, I don't want to criticize. There are lectures, if you go, they're just copying and pasting past medicine notes in 10-15 slides, and they will read and they will go off. I can do the same. I'll be paid in the same way, but I didn't want to do that. Okay, this latest classification hardly few people knows, but I had to bring it here for you all. All right, real exam question will be new pattern or same. Like real exam questions will be more like your actual past paper question. Past paper questions are actually picked up by past test people more than past medicine people. I'm not with past test or anything, because earlier I worked with past test. Earlier I worked with past test, but past test just like that, no one can get into and edit a question or anything. They have a lot of lot of breakers to get in, lot of interviews they are taking in. So I recommend past medicine, work of the MCQs, there is nothing wrong. But when it comes to management or query thing, just beware. If you actually subscribe to the online version of the past test and see the comment section, you would have seen how many users have totally trolled and questioned and gave very angry comments about their own questions. So I would suggest past medicine, it's okay to work out the question bank. I wouldn't say no. But whenever there is a controversy, go back to my slides, because my slides are actual screenshots of guidelines. None of the thing I'm even typing with my own hands or anything. So that should be your reference. That should be your reference, right? Not anything else. Guidelines should be your reference. Textbooks should be a reference. Nothing much should be a reference for anything. Now comes class 1D, that is a ranolazine. How many of you are using ranolazine in your day-to-day practice or anything? I don't know. Anybody here using ranolazine? Okay. Ranolazine. Okay, doctor, you're using ranolazine. Fine. I mean, may I ask, like, apart from angina, anything else for you're using ranolazine? Okay, we have a study going on. Ranolazine is one of the very good drug for VPCs, ventricular premature complexes. We are just in a study phase. Okay, what ranolazine does, it decreases the action potential, recovery time, and reduction in early after depolarization and triggered activity. You don't need to know all the terms. Just know ranolazine is class 1D. That's all I want you to know. Yes, PVC. Yes, that's a fantastic drug for PVC. And class 2. Again, class 2 has class 2A here. Class 2A are your non-selective beta and beta 1 adrenergic receptor inhibitors. They are your carvedilol, propranolol, nadolol. And these are your non-selective beta inhibitors. They had asked which of the following are non-selective beta inhibitors. You should be able to tell carvedilol, propranolol, and nadolol. And then also selective beta 1 adrenergic receptor inhibitors, such as your atenolol, bisoprolol, bitoxolol, celiprolol, esmolol, and metoprolol. I hope you all know what are the indications of this drug. Okay, these are your class 2, class 2A. Class 2B is again your non-selective beta adrenergic receptor activator, such as your isoproterenol. All right, again, it can use for your ventricular escape. Okay, or you can also use isoproterenol typically for definitive pacemaker implantation. And class 2C is your muscarinic M2 receptor inhibitors, such as your atropine, anisodamine, and hyoscine and scopolamine. These drugs have been included and incorporated into antiarrhythmic drugs. Now, atropine is an antiarrhythmic drug. This is the latest thing. The latest thing. We are bringing it to our lectures. This is the latest thing. Okay, it can cause mild to moderate symptomatic sinus bradycardia. It can increase SC node automaticity, all the mechanisms. You don't need to know the complex mechanisms. At least know class 2C what are the drugs. All right, class 2D. Class 2D are your muscarinic M2 receptor activator. What are the M2 receptor activators, such as carbachol, pilocarpine, methacholine, digoxin? Digoxin is your class 2D. It's used in sinus tachycardia, supraventricular tachyarrhythmias. Then class 2E, they have given for adenosine A1 receptor activators, such as your adenosine, aminophylline, all these drugs. All right. Then comes your class 3. Again, class 3 is same as the old classification. They haven't changed. Class 3s are your potassium channel blockers. In class 3A, non-selective potassium channel blockers, especially don't forget the name amiodarone. Okay, even if you forget the other names, don't forget the name amiodarone. You know the indications of amiodarone, ventricular tachycardia. We are going to see each and every drug separately. Okay, each and every drug we are going to see separately, but still for completion's sake, ventricular tachycardia, atrial fibrillation, and ventricular fibrillation, premature ventricular contraction. Again, you can try, and tachyarrhythmias associated with supraventricular arrhythmias and atrial fibrillation. And 1 second, sorry. Yeah. Again, these are the two additional drugs. These two are in study phase. You need not know these two slides. Now, class 3B, you should be knowing. Class 3B, they are bringing two drugs called nicorandil. Nicorandil mechanism of action, they asked opening up ATP sensitive potassium channel. Nicorandil or pinacidil. They open the ATP sensitive potassium channel. Okay, it's used in the treatment of stable angina. Okay, pinacidil is an investigational drug for hypertension. You need not know, but about nicorandil, you should know the mechanism of action. What is the use? In class 3C, again, these are under study. You need not know. And class 4A, they are brought your non-selective surface membrane calcium channel blocker like Bepredil. And class 4, at least you remember all the calcium channel blockers only. They just divided and subdivided again and again. At least know class 4 calcium channel blockers. There is not much change here, but always remember about other things. Class 3A, you remember. Class 2 has been further subdivided into class 2A, B, C, and D, and as well as E. That you should note it down. These two slides you can ignore. This, whatever I marked, it's more important for you. And class 4, just remember calcium channel blockers. Most calcium channel blockers. We are going to separately study about calcium channel blockers. Don't worry about that. Then class 5, they have included in the latest Vaughan-Williams classification. This class 5 is nothing other than your TRPC3 blockers. These are under investigations. At least know there is a class called class 5. Class 6 again under investigation. Class 7 is again important. Why it is again important is some of the very common drugs they had included in class 7. For example, ACE inhibitors has been included as an antiarrhythmic drug. ARB has been included as an antiarrhythmic drug. Surprisingly, your omega-3 fatty acid has been included as an antiarrhythmic drug, and statins has been included as an antiarrhythmic drug in the latest Vaughan-Williams classification. These drugs are called upstream target modulators. All right. You don't need to know all the complex mechanism. At least know these 4 drugs: ACE, ARB, omega-3 fatty acid, and statins. All right. What is the reason behind omega-3 fatty acid and statins? They reduce the cardiac myocyte death in post-myocardial infarction state. So they reduce the arrhythmia, they believe. And ARB, they have some electrophysiological effect. You don't need to know the complex mechanism, but at least you should know class 7 has these 4 drugs, which we know, but we don't know yet. We may not have been known that these are antiarrhythmic drugs. Okay, that you should know. Now we go to individual drugs. First, who is going to identify the culprit drugs? Sorry, but is the Vaughan-Williams classification 1, 2, 3, 4 to do with action potential? Yes, doctor. I will explain you one by one when we are going to see the individual drugs. You will know. I'll explain you which drug acts on which level. I'll explain you. Class 5, 6, 7. I say class 5 and 6 are under investigation. Okay. I have given the slide. If you are interested, that's TRP, transient receptor potential channel blockers. Okay. They are investigation. Class 5 and 6, you can very well ignore. Class 7 is the 3, 4 drugs you should never forget, because these are common drugs they incorporated into the classification: ACE, ARB, omega-3 fatty acid, and statins. Okay. They all have electrophysiological activity. Okay. Even if you don't know what is the exact electrophysiological activity, just remember the name. What they are telling is all this ACE, ARB, what it does, it reduces the ventricular remodeling. So the ventricular itself, remodeling itself is reduced. So the chances of arrhythmias are going to be decreased, because the remodeled ventricle is pro-arrhythmic ventricle. So the chances of arrhythmia is decreased here. So that is the reason they have included these drugs as well. All right. Now we are going to go to the individual drugs. Okay. First question. All right. You are welcome, doctor. A 23-year-old man presents to the emergency room complaining of prolonged episode of palpitation. He reports he has intermittent episode of palpitation, which he describes as rapid, regular over the last few months. However, the episode usually stop on their own. A 12-lead ECG reveals a wide complex tachycardia at a rate of 136. In looking at ECG, that was done at a routine primary care appointment, you notice presence of delta waves. You begin to suspect the patient may have WPW. Since his blood pressure is stable, you are trying an intravenous agent to treat his patient's arrhythmia in the short term. Okay. The long-term use of the medication may lead to lupus-like syndrome. What is the drug? Who will answer me? Who is the culprit? Here, simple thing, a guy with WPWA, you are giving a drug, and the drug leads to lupus-like syndrome. Which drug leads to lupus-like syndrome? Here in Wolff Parkinson's White, which drug? Obviously, this is the culprit drug. This is your procainamide. Okay. With this, we are going to start with class 1 antiarrhythmic drugs. I'm not going to explain the all the classes. I'm going to explain which is very, very important. The first 1A are your quinidine, procainamide, and your disopropamide. Okay. Mechanism, it binds to activated sodium channels and block the inflow of the sodium ions in the sinoatrial node and cardiac myocytes. Just know what I'm underlining. That's more than enough. And second thing, it also decreases your pace zero depolarization of the cardiac action potential is prolonged here, and pace 3 also delayed. Okay, know the drugs, where it acts, sodium channel. Also it acts on pace 0 and pace 3. What are the side effects of this drug? May cause cardiac arrhythmias, including torsades de pointes due to QT prolongation. Very, very, very important. All these drugs can precipitate your torsades de pointes, that is your QT prolongation. What is meant by torsades de pointes? It means twisting around the points, where there will be polymorphic ventricular tachycardia. Different QRS morphology will be there. One will be like this, one will be like this, one will be like this, one will be like this. That is what we call as polymorphic VT or torsades de pointes. Be very, very careful. Class 1A drugs, quinidine, procainamide, and disopropamide. All right. Quinidine, the adverse effect is going to be your synchronism. They will ask you. Okay, like how for procainamide we have a lupus-like syndrome, quinidine can cause synchronism. Okay, because it is derived from cinchona alkaloids. What is the synchronism? Typically, it can cause vertigo, headache, tinnitus, and psychosis. Another drug that can cause synchronism is your salicylic acid derivatives. Again, all those drugs can cause synchronism. Typically, they will give you in the question stem, the patient is having vertigo, patient is having tinnitus, patient is having some kind of psychosis. You have to suspect any synchronism is there. And procainamide, like I said, can cause drug-induced lupus. Disopropamide, the adverse effects are urinary retention, double vision, and constipation. Suppose if they are giving a case history, after taking an antiarrhythmic drug, the patient has developed urinary retention and double vision, you have to suspect which drug? Your disopropamide. All right. Be very, very clear. Then class 1B antiarrhythmic drugs, like I said, lidocaine and mexicillin. How it acts, that's only point you need to know. It binds to both activated and inactivated again sodium channel by blocking inflow of sodium channel into the cardiac myocyte. It has some action on phase 3 repolarization as well. And about class 1B, things you should know is the indication where we are going to use class 1B, ventricular fibrillation and ventricular tachycardia. I hope all of you know your ALS protocol. Okay, adverse effect. Okay, what adverse effect class 1B can do is your cardiac arrhythmias. It can cause your cardiac arrhythmias. And prolonged high doses of lidocaine can lead to neurotoxicity and mental status. They will ask you one question. Lidocaine you can also use as your local anesthetic. Suppose a local anesthetic become toxic, what you will do? What drug you will do to reverse the local anesthetic toxicity? They had asked. A local anesthetic toxicity, lidocaine toxicity, what drug you can give, what treatment you will give immediately? Anybody knows? What antidote you will give someone with a class 1B, that is a lidocaine toxicity? Yes, fantastic, Dr. Ovais, that's lipid emulsion. Or intralipid, lipid emulsion or intralipid is the drug you have to give here. In class 1C, again, your flecainide, propafenone, and morizine. This we are not using much. Flecainide and propafenone are in the market. It blocks again the flow of the sodium ions into the cardiac myocyte. Okay, it's used to treat SVT. Flecainide, I said, fill in the pocket. Will always remember. It exacerbate or induce life-threatening arrhythmias, so avoid in structurally abnormal heart. Always remember, whenever they have given a history, something like that, and they are telling the patient is already having a cardiomyopathy and the patient is already on a failure and he is starting some atrial fibrillation, never ever give flecainide as the first choice drug. Never ever give flecainide as a first choice drugs. It's completely contraindicated in structurally abnormal heart, or anyone with a depressed left ventricular ejection fraction, or any ischemic heart disease, a patient with acute coronary syndrome. Okay, completely contraindicated. Flecainide or combination. Flecainide is completely contraindicated, especially and typically it's better to avoid all class 1C in such cases. Pill in the pocket is flecainide. We typically give flecainide as pill in the pocket. Then class 3 antiarrhythmics. Class 3 antiarrhythmics are, your amiodarone, your sotalol, your butylide, dofetilide, and terlium. Again, I'm telling you, this classification I'm typically taking based on the old classification, and the new classification, just note it down, what are the new things added. For a safer side, I gave the new classification. Suppose if they are going to ask you any questions from this, people who attended this lecture should not miss that out. That's my only aim. All right, class 3, it acts by binding to potassium channel and blocking the flow of potassium ions. That's why they are called potassium channel blocker. It acts on the phase 2 and phase 3 repolarization is prolonged as a result of that. Okay. And ECG, what are the ECG changes here as a result of that? Once the potassium ion channel is blocked, there can be prolonged QT interval. And sotalol also has a potent beta blocking activity. It's a type of beta blocker, but still it's an antiarrhythmic drug. Okay, indications. Dofetilide and ibutylide can be used to treat atrial arrhythmias. Terlium we are not using much, and sotalol and amiodarone have been used suppression of both atrial as well as ventricular arrhythmias. For both, you can cause. And class 3, again, they can cause antiarrhythmia, cause cardiac arrhythmias, including torsades. Always know one thing: all antiarrhythmics, all anti-A are proarrhythmics. That's what they do. Any antiarrhythmic drugs can cause some other cardiac arrhythmia at one point of time. Okay. Other adverse effects are bradycardia. For example, drugs like sotalol can cause bradycardia because it's a beta blocker. And hypotension, of course, it can decrease the blood pressure. This is your class 3 antiarrhythmic drugs. Then we are going to go into the calcium channel blockers. Calcium channel blockers, you should know what is the 2 types of calcium channel blockers. They had asked this previously. Voltage gated T-type channels are there, and voltage gated L-type channels are there. These are 2 types of calcium channels. T-type channels are your low threshold, fast inactivated calcium channel that is found in the pacemaker cell and vascular smooth muscle. They haven't asked, they may ask where you will find T-type calcium channel. Okay. And L-type calcium channel, they are typically found in all type of excitable cells, including your cardiac and your vascular smooth muscle cells. All right. With this, we are going to go to the very first drug. And this is how we are going to learn it throughout. I don't know how to hide this thing. Better I'll just push it down here. Yeah. Class 4 antiarrhythmic drugs are your calcium channel blockers. I wanted all of you to know what are the 2 types of calcium channels and where they present. It's very important. And class 4 are your calcium channel blockers, including your verapamil, diltiazem, okay, which are considered non-dihydropyridine calcium channel blockers. The name itself says it blocks the voltage-gated calcium channels. Okay, especially in the SCA node and AV nodal cell, it slows phase 4 spontaneous depolarization. That's how it acts. All right. What are the clinical uses? Supraventricular tachycardia we can use. What are the adverse effects? Hypotension, heart block, and constipation. Typically, verapamil is a drug that can cause constipation, that can cause severe constipation. Also, it can cause headache. Can also cause headache. These are your calcium channel blockers. Typically, we use non-dihydropyridine calcium channel blockers. That is your verapamil and diltiazem. Other antiarrhythmics, potential antiarrhythmics, are your adenosine, like we saw. Again, it can increase the potassium influx. How it acts? It acts by increasing the potassium influx into the sinoatrial node and AV node. Clinical uses, again, for supraventricular tachycardia, we use adenosine and also used as a cardiac stressor agent for cardiac stress. And the adverse effect of adenosine are going to be a flushing, dyspnea, chest pain, hypotension, and your heart block. Adenosine can lead to all these things. That's why adenosine has to be given. How many of you, I don't know, how many of you have given adenosine to the patients? How you will give typically? It's a very short acting, right? How many of you have given adenosine? You know, you should be able to answer this. How you give adenosine to a patient typically? All right, potassium. Many times, yes. The way you give adenosine, you have to, yeah, lift the arm. Yes, exactly. IV flush, 6 milligram bolus. Just you have to quickly flush because it's a very short acting drug. Potassium, again, it can be used to suppress your ectopic pacemakers. Okay, and also the ones with your digoxin toxicity, because hypokalemia can potentiate digoxin toxicity. We are going to see that. Potassium can cause hyperkalemia and cardiac arrhythmia. Magnesium, again, it can be used because especially for torsades, we use magnesium. Also, it's used to treat digoxin toxicity. Okay, these are some of the few points we need to know about other antiarrhythmic drugs. Now we are going to come to individual drugs. First drug is your nitroglycerin. Okay, what are the drugs? Because I just took this in a flashcard format so that everyone will feel it easy to read and easy to just revise and go through. Just note down the certain things. What are the other similar drugs in nitroglycerin group? Isosorbate nitrate, dinitrate, isosorbate mononitrate, and amyl nitrate. What happens? How it acts? Next point is it converted into your nitric oxide. Nitric oxide, what it does? It increases your cyclic GMP. Okay, this result in the dephosphorylation of your myosin light chain. This will ultimately relax the smooth muscle and it causes dilatation of vessel. How nitroglycerin acts? It goes, increases your cyclic GMP, then it dephosphorylates your myosin light chain kinase, relaxation of smooth muscle, and dilatation of your vessels. It's used in the treatment of angina. It's used in the treatment of pulmonary edema and heart failure. Adverse effects are very important. It causes headache due to vasodilatation of cerebral vessel. Typically, it causes headache. Nitrate patients, they will typically tell we have severe headache due to vasodilatation. It can also lead to your hypotension. It can potentially decrease the blood pressure. Okay. Another important adverse effect you need to know is long-term use of nitrates will lead to something called development of tolerance of the drug. The drug tolerance. As a result of that, even doesn't matter how many nitrates you are going to give, the patient won't have any effect based on that. So you need to give something called as your drug holiday. You need to give drug holiday for a couple of days, maybe a week. You have to withhold the drug and you may be replacing with some other drug. Then you have to again start the nitrate, because excess nitrate can lead to tolerance. Long-term usage of nitrate can lead to tolerance. This is about nitrate. You know the mechanism of action, clinical use, adverse effects. All right. Now comes to the next drug, your nitroprusside. This again metabolized into your nitric oxide. Okay. Nitric oxide, same mechanism of action. It is used in acute management of hypertensive crisis. I hope all of you know. And severe heart failure and cardiogenic shock, we give nitroprusside. We give sodium nitroprusside. Okay. It can be only given intravenously. Why? Oral administration results in the formation of cyanide via hydrolysis of nitroprusside in gastrointestinal tract. This is a very important point. Nitroprusside, I hope some of you might have given in a patient with severe hypertension. It can be given only through IV route and no other route. Okay, only through IV route. Another important thing is sometimes this drug can lead to cyanide toxicity. Okay, in such case, you have to give a drug called thiosulfate. They had asked once for part 2 people, not for part 1 people. Part 2 people, they had asked, a patient has been given a rapid bolus of sodium nitroprusside IV and the patient has developed cyanide toxicity. How will you manage the patient? Then you should be able to tell the name thiosulfate. This is the drug used to manage the cyanide toxicity due to nitroprusside. Now identify this drug. A 53-year-old woman with a history of hypertension, diabetes presents to your office complaining of a chronic cough. Upon further questioning, she denies any fever, chills, sweats, or any illness. She denies cigarette use too. Her medication include an oral hypoglycemic agent and an antihypertensive agent she has been using 3 months ago. Physical examination reveals normal BP. Lung examination is not significant. You suspect patient's cough may be related to the new antihypertensive medication. What medication is that? Cyanide toxicity symptoms, I will come to the doctor. We are going to learn all those things in the part of your clinical toxicology. Yes, AC inhibitors, captopril, lisinopril, absolutely, you are correct. This is your AC inhibitors. You know all the names. That's for your lisinopril, enalapril, captopril, benzapril, fosinopril, moxapril, and acquininapril and trimipral. All these drugs are your AC inhibitors. They inhibit angiotensin converting enzyme and peptidyl dipeptidase. All these things you know very well. Only thing they are going to ask you is the clinical use of AC inhibitors and adverse effects. They are not going to ask you complex pathophysiology and how it acts. Here you should know it's used in the treatment of hypertension, congestive cardiac failure, and also used in the treatment and prevention of diabetic nephropathy. It's very, very important. Diabetic nephropathy. How it acts is it acts on the efferent arterioles. Okay, always remember it acts on your efferent arterioles. Also, it decreases the mortality in post myocardial infarction. How you know? By prevention of ventricular remodeling. Okay, these 2 points, always remember how it delays the progression of diabetic nephropathy or treat and prevent the diabetic nephropathy is by acting on the efferent arterioles, and it decreases the proteinuria. And in the heart, it stops ventricular remodeling. That's why post-MI patient and high-risk cardiovascular patient, we are still prescribing AC inhibitors. What are the adverse effects? It can cough, can increase the potassium level, and renal failure, especially in patients with renal insufficiency. You have to be very, very careful, and you have to be very, very careful even in the patients with efferent doctor, EFF, C, EFF, efferent arteriole, not the afferent arteriole, efferent arteriole. All right. And it may cause fetal and renal damage if used in pregnancy, so it's pregnancy contraindicated drug. And it can cause angioedema. They had asked why there is an angioedema in AC inhibitor because of release of your bradykinin. These 3 things, whichever I'm writing, is very important. Bradykinin, efferent arteriole, ventricular remodeling. Don't forget. An adverse effect, cough, hyperkalemia, and it's risky in case of renal failure, renal insufficient patient, and it's a teratogen, and it can cause angioedema. All right. Now comes this drug called aliskiren. They haven't asked, but better to learn. Mechanism of action is directly it inhibits the renin. Directly it inhibits the renin. That one word you know, that's more than enough. Okay, you don't need to know complex things, because from now onwards we are going to make the pharmacology simple and just few lines of what is needed for you. It inhibits renin. Know that. That's more than enough. Clinical uses, it's used in the treatment of, again, in the hypertension. It's a direct renin inhibitor. That's it. Side effects, again, it inhibits the renin, so it's going to cause renal failure, hypotension, hyperkalemia, and angioedema. Okay, and always remember, never ever use aliskiren with AC inhibitors. As a result, it can potentiate the renal failure, it can potentiate the hypotension, it can worsen the hyperkalemia, and it can lead to life-threatening angioedema, because both the drugs are acting in the same pathway. All right, almost the same pathway. Now comes to calcium channel blocker, and I hope all of you know what is dihydropyridine calcium channel blocker, what is non-dihydropyridine calcium channel blocker. Some of you may have some confusion. Please remember, dihydropyridine calcium channels are your amlodipine, nifedipine, nicarbidine. Okay, non-dihydropyridines are your verapamil and diltiazem. All pidine, and all dihydropyridine. Okay, then the rest of the drugs, verapamil and diltiazem. Yes, Dr. Haider, it can cause nephropathy, it can cause also renal failure. It won't cause renal failure. It is contraindicated in patient with renal insufficiency. That's a totally different thing. It won't cause a renal failure in a normal patient. For example, if I develop the blood pressure, or maybe if I develop some pre-diabetic state, I have to be stopped from progressing into diabetic nephropathy, I can take AC inhibitors, it won't affect me. At the same time, if a patient is there already having some renal issues, it's better not to use AC inhibitors in that. Okay, these are 2 entirely different opposite things. Okay, got it. That's good. Mechanism of action, it blocks voltage gated L-type calcium channel. I told you L-type and T-type calcium channel. Just know it blocks L-type calcium channel. Uses hypertension, Prince metal angina, vasospastic angina. I explained that. And Raynaud's disease, again, you can give calcium channel blockers. Calcium channel blockers. Adverse effect, I already told you, again, bradycardia, heart block, peripheral edema. This has been asked. Which of the following drugs can cause peripheral edema? They had given 5 options, and one of the notorious drugs is your amlodipine. This amlodipine can cause peripheral edema. Always remember that. Okay, and also we have to be used very cautiously. We have to use this drug in patients with decreased ejection fraction because of negative inotropic effect. All right, I hope you know about the calcium channel blockers now. Next, who's going to identify this drug? A 42-year-old avid mountain climber with no significant past medical history presents to your office complaining of weakness, dizziness, headache, nausea every time he rapidly ascends large mountains. The symptoms are usually mild. They tend to last for a few days. He asks whether there is any prophylactic treatment that he may be able to take beforehand in order to prevent these symptoms from occurring. You decide to prescribe a medication for him that can enhance performance skills and diminish the symptoms of mountain sickness. What is the drug? Which drug you prescribe anyone who is going to have a mountain sickness? Yes, it's a good old acetozolamide. Again, thing they're going to ask you, what is the drug called? Carbonic anhydrase inhibitor, important. And the drugs are dorzolamide, brinzolamide. It inhibits carbonic anhydrase in the proximal convoluted tubule. Whatever I'm underlying are the most important thing. Rest you can ignore in this slide. Okay, that's why I'm using a pen here. It uses important to treat glaucoma, to alkalinize the urine in case of toxic ingestions, especially salicylate or barbiturate's toxicity. We can use this. It's also used in the treatment as a prophylaxis for your high altitude sickness. Okay, because it has propensity to decrease the CSF production. Okay, and also it can be used as a diuretic in patient with metabolic alkalosis. These are the 3 things. Because of the decreased CSF production, there is a thing going on whether this can be used as an adjunct in treatment of epilepsy, but I don't know how successful is that. Adverse effect, hyperchloremic metabolic acidosis. Always remember, it's not alkalosis. Hyperchloremic metabolic acidosis is the adverse effect of acetozolamide. Please remember hyperchloremic, because they had asked this once. Metabolic acidosis is the ADR. Okay. Also, it can cause hypokalemia. It can cause sedation. It can cause neuropathy and can cause allergic reaction in patients with pre-existing sulfur allergy. Okay. Other effects, it can increase the secretion of sodium, potassium, and calcium and bicarbonate through the urine. These are the other adverse effects of acetozolamide. Straightforward. Know what are the other drugs, mechanism of action, clinical use, adverse effect. That's it. Then comes your furosemide. These are your loop diuretics. Other type of loop diuretics are bumetanide and torsemide. We use torsemide and furosemide, not much of bumetanide anymore. And furosemide is again a type of sulfonamide derivative. They may ask you. Okay, they may ask you. It's again a type of sulfonamide derivative. What it does, it blocks your sodium potassium 2-chloride transporter in the ascending portion of loop of Henle. This they had asked. Furosemide acts where? They're given all the options: PCT, DCT, descending loop of Henle, ascending portion of loop of Henle, collecting duct. All the 5 options they have given. Twice they had asked about this drug in MRCP part 1. So very important drug. It acts on the thick ascending portion of loop of Henle. They may give any confusing options. Be very clear with this. Clinical use to treat volume overload states and as well as heart failure. I hope all of you know. Liver failure, again we can try renal failure, hypertension, and hypercalcemia. Furosemide decrease the calcium levels. Adverse effect, again hypokalemia. 2 important adverse effect you should know is your ototoxicity. Very important adverse effect, and it can increase uric acid levels and it can precipitate your gout. One of the notorious drugs to precipitate gout is your furosemide. Very, very important, and it can cause sulfur allergy because furosemide itself is a type of sulfonamide. It can cause sulfur allergy. Always remember. Remember where it acts: sodium, potassium 2-chloride transporter, where it is located, thick ascending portion of loop of Henle. Okay, they may confuse you with anything: thin ascending portion, descending portion. Always remember thick ascending portion of the loop of Henle, sodium, potassium 2-chloride transporter. And the adverse effect, especially two adverse effect, don't forget, it can cause autotoxicity, can increase uric acid and causes gout, and also sulfur allergy. Right? Ethacrenic acid acts in the same way, but we are not using that much. Now identify these drugs. A 65-year-old man with no significant past medical history comes to your office for a follow-up visit. He is feeling well, although he reports 2 visits to the emergency room over the last 3 months for kidney stones. Discharge paperwork from the emergency room reveals patient's kidney stones were composed of calcium oxalate. Physical examination is significant for higher blood pressure, but otherwise normal. Initiate a workup to evaluate onset of his nephrolithiasis. But in the meantime, you decide to start him on a medication that will treat his hypertension and nephrolithiasis. Which drug is that, doctor? Which drug you will give in this gentleman who has a hypertension and as well as nephrolithiasis? So there is one drug that is going to go and compete and treat both the conditions of this gentleman. What drug is that? Excellent. That's thiazide diuretics. Thiazide diuretics. That's the next drug we are going to see. Thiazide diuretics, it can also include chlorothiazide, metolazone, chlorthalidone, indapamide, all are thiazide type diuretics. Okay. Where it acts, again, very, very important. Okay. Because we are going to just see what exactly needed for your exam, nothing else other than that. It inhibits sodium chloride co-transporter in the distal convoluted tubule. Everyone, please note it down. This is very, very important. Where it acts, extremely important. It inhibits sodium chloride co-transporter in the early distal convoluted tubule because they are very notorious to give another option as late distal convoluted tubule. At the exam hall, we may get so tensed and frustrated and we may end up forgetting things. Always remember, inhibit sodium chloride co-transporter in the early distal convoluted tubule. Same way for thiazide, for loop diuretics, thick ascending part of loop of Henle. Like that, you should remember. Okay. Uses always going to be a hypertension, and one important use here is going to be a nephrogenic diabetes insipidus. Thiazide diuretics are used in your nephrogenic diabetes insipidus and recurrent kidney stones, especially the stones that are made of calcium oxalate. Recurrent calcium oxalate stones, you can use thiazide diuretics. Adverse effect, it can cause hypokalemia, and two important adverse effect you should know is your hyperglycemia and hyperlipidemia. Typically, I avoid thiazides as a standalone hypertensive agent in case of any diabetic patients or in case of any patient in a metabolic syndrome, because it is going to actually worsen their progress. It's going to again increase the blood sugars. It's going to again increase the lipid levels. And hyperuricemia, again another adverse effect. It can precipitate your gout. That you should know. Why it is used for calcium oxalate stone? It decreases the secretion of calcium in the urine. That is the one big reason we are always using that in treating the calcium oxalate stone. This is your thiazide diuretic. Now identify this drug. A 47-year-old man with a history of hypertension and heart failure presents to your office complaining of enlarged breast in a man. I hope all of you know what is an term for enlarged breast in a man. See this. He reports his breasts have grown in size over the last 2 months. He has become increasingly concerned, embracing gynecomastia. Which medication, which antihypertensive regimen would have caused this? Yes, everyone got it. This is your good old spironolactone. Other aldosterone receptor antagonist are your eplerenone. This can cause little less gynecomastia compared to the spironolactone. All right, this can cause less gynecomastia compared to spironolactone, but still the adverse effect is adverse effect. It's going to be there. What is the mechanism of action? It's a competitive aldosterone receptor antagonist. Just know this: competitive aldosterone receptor antagonist. Remember the word competitive because they may give an option and confuse you. Non-competitive, whatever, but it's a competitive. And urinary potassium excretion is decreased. So what is the treatment? Where we are using this? Your primary hyperaldosteronism, volume overload syndromes, heart failure, hypertension, and it's also used to treat female hirsutism associated with PCOS. This is an important point you should be knowing. There are other treatments for hirsutism available, but spironolactone is one of the treatment. Since it retains the potassium, it can lead to hyperkalemia. It can cause metabolic acidosis. It can cause gynecomastia. GA upset, almost every drug causes that. Leave it. Eplerenone, like I said, has a little anti-androgen effect. Okay, with gynecomastia often seen with associated with less gynecomastia. I won't say they're given not. It can be, but it won't produce any obvious gynecomastia. It can be embarrassing to people. All right. This is about your spironolactone. Then comes another drug called triamterene. Okay, its actions are similar to your amiloride. Triamterene blocks the epithelial sodium channels. Just remember what I'm underlining and putting in mark. For all the drugs I'm going to tell you from now on. It blocks the epithelial sodium channel. It is located in the distal cortical collecting tubule of nephron. These 2 points are very important. Where it acts, where it is located in the nephron, you should be knowing that. Nothing else you need to know. No need to know anything that is unwanted. You know where the drug acts. It blocks the epithelial sodium channel. That is your ENaC. All right. It's your ENaC. Where it's used to treat. Okay. Here also it decreases the urinary potassium, also decreased. Used in combination to treat volume overload, heart failure, and hypertension. Also used as a diuretic in patients, especially like your Addison's. Right. Adverse effect are going to be again hyperkalemia, metabolic acidosis. It can cause your GI upset. This is about triamterene, which acts similar to your amiloride. One more drug. A 68-year-old man with a history of hypertension and diabetes presents to your office complaining of erectile dysfunction. He tells you that he has suffered from erectile dysfunction for several years from now, but that now he has a sexual partner he would like to treat it for his condition. You assure him that you can prescribe a medication that will help you. Okay, this new medication is with nitrates. It can be fatal. With nitrate, you warn him this medication should not be taken with nitrates, which can be fatal. Which medication that is used to treat erectile dysfunction should not be used with nitrates? Absolutely, this is your sildenafil. It can be vardenafil, tadalafil, ammonafil. It selectively inhibits cyclic guanosine monophosphate specific phosphodiesterase type 5. So many times they had asked type 5, always remember type 5 phosphodiesterase it inhibits. All right, type 5 phosphodiesterase it inhibits. Just know it is used, 2 uses of sildenafil and tadalafil, erectile dysfunction, pulmonary artery hypertension. 2 uses. Adverse effects, it's contraindicated in patients using with nitrates. They will ask you the same way, which of the following drugs should be avoided in a patient who is already put on some sodium nitroprusside or any other nitrate? Sildenafil, right? Sildenafil. I think I can continue for another 30 minutes and we can stop. Do you guys need a break or shall I continue? Or is it overloaded? Because we have to finish a lot of things within 4 days. I'm going to cover all the drugs. So I want your opinion on it. Is it okay to continue for another 30 minutes or you want to start tomorrow again afresh? It's up to you guys. I think it's a lot for today. All right, no problem. I'd love to take a break, but tomorrow I want you guys to stay a little more. Then only we will be able to cover and complete a lot of the slides, because otherwise we will miss out things. I don't want to miss anything. Okay, so I want all of you to come up tomorrow like around 8 o'clock, like in Indian time, or like 2:30 p.m. GMT. Okay, and we can start and we will just try to wind up a couple of things. How should we approach to clinical pharmacology? Start earlier if possible. Okay, clinical pharmacology. Yes, that's more than enough. That's why I'm marking what you need for a drug. You don't need to know all the other things. Just when it comes to a drug, just follow me. I can guarantee you it's fine. You will be fine. And also other thing is like, other thing you need to know is the clinical use and the adverse effect. Nobody's going to ask you anything beyond that. The reason I took general pharmacology is for completion set. You should be knowing that. Without knowing that, I'm just displaying one by one drug sildenafil, okay, inhibits this, the adverse effect. It won't make any sense. The lecture, anything should be complete. That's why I got it. 2:30 p.m. UK time, doctor. I think I'm fine with that. I don't know about other people. But at least for the next 2 days, at least I will need 2.5 to 3 hours of every day, because it's a workshop. Then only I can complete all the drugs and we can discuss the MCQs. Otherwise, it will become 4 to 5 days. So little bit tomorrow you come early. Tomorrow we don't have general pharmacology, so it's not going to be boring. We are going to quickly see the drugs and we are going to tick off and keep moving. So you no need to worry about anything. Okay, quickly we are going to tick off and keep moving. Okay, so tomorrow we will start at the same time, or maybe if earlier, you can tell in the group, we can start little early also. That's perfectly fine. And Dr. Mohammed asked a question, ARB same as AC, or, and I mean, like ARB and AC are two different entities, doctor. AC inhibitors, though both acts on the same way, AC inhibitors, they stops the conversion of angiotensin converting enzyme. ARB goes and blocks the drug at the receptor level. That is why ARBs doesn't have any adverse effect like dry cough or anything. How much general pharma need? Just whatever I put on the general pharma slides, that's more than enough. Just know what is what. And certain things, like I said, inhibitors and enzymes acting on where, whatever I mentioned then and there, that is important. That you cannot evade from those things. And what are the types of prodrug? You cannot escape from that. And some of the formulas I had told you, you cannot escape from them. That is very important. That's why I covered everything. So tomorrow, please try to be here little early if possible. We need at least 2-3 hour session tomorrow and day after. I am ready to sit for you guys and study. Okay, and not a problem at all. Okay, we will see tomorrow. Take a break, and if possible, you all can reply in group, so that if you majority of you people are going to come early tomorrow, I am ready to start early tomorrow. Maybe even 30 minutes or an hour early also, that's fine. I can start so that it will be helpful for everyone. Okay, I'm stopping with slide number 101 and we will resume tomorrow. Okay, all right, you're most welcome. Thank you, doctors. Thank you so much. Okay, see you.